Welcome to this second teaching session, useful for all the EDIC Part 1 aspirants. And I have covered in my previous class already on the acute ischemic strokes and disturbed consciousness. So basically, as far as neurology is concerned, we have divided into four important subsections. So already two we have covered in the previous class, and the rest two I will try to cover because this is a quite again a big session, and you have to be very patient with me throughout this course of session, and and hold tight all of you. And if you have any important question or query, you can just put in the chat box at the end of the session. I will try to answer. Right. So I will also I have included few of the MCQs, both A types and K types. So I would like all of you to participate in these MCQs, which are real MCQs, and you can just put your responses in chat box if you have any. No need to speak. All right. So can we go ahead? So this is I'm going to start with just this important MCQ. So in relation to patients with weakness in critical care, so what are your responses? This is a K type, false, true, and false type. So you can just okay. So any guesses? So this is going to be a long session on neuromuscular disease. So before that, I just want you to squeeze your mind and come out of with some beautiful answers and options. B. So you have to put true and false, right? Yes. Okay. True, false, 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 true. Okay. Any more? Okay. Okay. So this is wrong. In myasthenia gravis, IgG autoantibodies block the synaptic. So as opposed to what you have answered, this is actually postsynaptic receptors which get affected by autoantibodies. Okay, so this is wrong. Postsynaptic rather than presynaptic. Second option is wrong because this is descending flaccid paralysis. Symmetrical ascending flaccid paralysis is a feature of GPS. Intensive care acquired weakness often involves the cranial nerves. It is actually not. The facial muscles and cranial nerves are spared. And D is also wrong. IVIG is more effective. Basically, both are equal. As far as efficacy is concerned, IVIG and plasma exchange or therapeutic plasma exchange both are equal as per various studies, and so we will explore it more in subsequent slides. Right, last answer is correct, as I think many of you have answered it correctly. P is correct. So just to explore the last point, respiratory muscle involvement in any neuromuscular disease. So how to assess it? So clinically, obviously, you can see the accessory muscles and nasal clearing. And if patient is on mechanical ventilation, you can count rapid shallow breathing index. If it is more than 105 or 135 in case of COPD, that is respiratory muscle involved so much. And these patients especially pose challenge for weaning an extubation later. And remember that respiratory muscle involvement, because this is a type 2 respiratory failure, so blood gas is not at all reliable. And it is also a late indicator, very late, and late feature or late sign. PCO2 is rising, that is very late sign of respiratory muscle involvement. So we don't do blood gas to detect or to say that the respiratory muscles are involved. It's too late and unreliable also. So what we do is just test the forced vital capacity FEV1 and PEFR. These spirometric assessments have been proposed ideally to say that patients have respiratory muscle involvement. So FVC less than 1 liter or decline more than 50% from baseline, or maximum inspiratory force less than 20 should be an urgent consideration, or should be an indication for mechanical ventilation in cases of GPS. So there is a rule called 20-30-40 rule for the prediction of imminent respiratory failure in GPS or any neuromuscular disease, or it's also a predictor of requirement of mechanical ventilation. The 20-30-40 rule. So less than 20 ml per kg of FPC, or less than 1 liter, or less than 50% decline, more than 50% decline from the baseline FPC. Okay, so this is FPC less than 20 ml per kg or less than 1 liter. Or maximum inspiratory force or maximum inspiratory pressure less than 30 centimeter of water, or maximum expiratory force or pressure less than 40 centimeter. So these three you have to remember always. I mean, the MCQs may be asked on this. And there is one important clinical scoring called Erasmus GBS respiratory insufficiency score, or EGRIS, also known as EGRIS. So you have to calculate based on the days between onset of weakness and admission. If it is less, it's severe, or require or facial or bulbar weakness at admission. If it is present, more severe, or MRC sum score. So this is a special score. This you need to remember, MRC sum score, that will come also in all kinds of neuromuscular disease. So the maximum score is 16. Okay, so lesser the score, more is the involvement of muscle. So to elaborate MRC sum score, before that, remember that EGRIS score 5 to 7 is related to high risk of respiratory insufficiency. So just to be very simple, you remember EGRIS score, right? The EGRIS score predicts the risk of developing respiratory failure apart from your 20, 30, and 40 rules. And if the score is high, like 5 to 7, the patient is at a higher risk of requirement of mechanical ventilation or respiratory failure, right? So regarding MRC sum score, so this is done to rule out the muscle weakness in ICU acquired weakness as well. So you will see this score in ICU acquired weakness as well, and this is basically the score, clinical score. You test all the 6 groups of muscles and you give the grading, right, from 0 to 5. This is the MRC grading of motor power. So you give this grading to each group of the muscles tested on the both sides, and total score is so 6 and 6, so 12 muscle groups are tested. Okay, and total score is 60, and score less than 48 defines the ICU acquired weakness or significant weakness in any other case. So this score is used in the EGRIS score as well. So you just remember, it's boring, but it's important. Now, moving to the important part, that is weakness or muscle weakness in ICU. It could be pre-existing or primary type of weakness, or it could be ICU acquired weakness. Okay, so we see both types of things in ICU patients who are admitted. So so we are going to discuss everything about weakness today. So pre-existing weakness could be Guillain-Barré or botulism, tetanus, myasthenia gravis, motor neuron disease, or myotonic dystrophy. So these are pre-existing type of weaknesses. In ICU acquired, we have about 4 or 5 types of disorders in which the intensive care unit acquired weakness is the most common one. About 50 to 60% of ICU patients develop the ICU acquired weakness due to critical illness itself. Okay. Then the less common causes are prolonged neuromuscular blockade or metabolite, electrolyte disorders, or some other rare and related conditions. So determining the cause of weakness and the level of weakness. So anatomically, we can, classify the weakness into various types, whether it is involving the spinal cord, endocrine cells, or motor neuron, or the muscle end plate and muscles. So, 5 levels are there at which the weakness can manifest due to various diseases. So, classical localizing signs we should be aware of. These are clinical signs, the bedside signs we should be aware. Like focal signs, focal neurological deficit will be present in all upper motor neuron types of weaknesses, whether this is absent in other level. In upper motor neuron, it will be present, focal neurological signs, like the just one, yeah, like plantar, okay, or tone and reflexes will be increased in the upper motor neuron, and it will be decreased in lower motor neuron and neuromuscular junction. So it may be normal, reflexes may be normal in NMJ type of diseases like myasthenia gravis, but if it is myopathic, may be normal. Okay, the tone may be normal, and the reflexes will also be normal in myopathies, muscle issues. Sensation will be altered in upper motor neuron type of disorders, even in lower motor. In few cases, it may be altered, but will be unaltered or intact NMJ and muscle issues, muscle level. Regarding the muscle mass or wasting, there will be late wasting, okay, in upper motor neuron later on because of denervation. Early wasting in the lower motor neuron lesions. So this is an important significant difference between upper and lower motor neuron lesions. And again, in neuromuscular junction, it will be late wasting, okay. And in case of myopathy, it will be variant. Then there are other signs, as I said, Babinski and Hoffman's sign will be positive in case of upper motor neuron. Fasciculation is a feature of lower motor neuron lesions and disorders, and fatigability will be present in case of neuromuscular junction disorders, and muscle pain, especially inflammatory myopathy, is present with the will be present in the myopathies. Okay, now this question. This is A type. A 66-year-old man presents with 1 week history of diarrhea and vomiting. He complains of severe back pain and generalized weakness and is admitted to his local ED. He has reduced power in lower limbs. He is ataxic, tachypnic, and has double vision. He has a normal CT of brain. The next most appropriate test for the list below would be. So this is single best answer. So urine dipstick, definitely not. Yeah, MRI of the brain is not. So what is your diagnosis here? Okay, so this is GPS because this is ascending paralysis. However, it is not written, it is just written like a generalized weakness. But there is a double vision, ataxia, so mostly Miller-Fisher variant type neuromuscular disorder, mostly myasthenia gravis. Okay, so spirometry is yes, because it will tell you the requirement of mechanical ventilation or the predisposition to the type 2 respiratory failure. Spirometry test is the most important test here to assess because we have to save the patient first. So this is the most appropriate test. Right. Now regarding test, what are the investigation which we require or we should order? So serum myoglobin or creatine kinase will be ordered in case of it will detect the rhabdomyolysis and many myopathies. So basically, myopathies will be detected here. It will be elevated. High VSR and CRP again in case of inflammatory myoneuropathies. Immunological studies or immunological panels you would order and it will be able to detect the GBS and myasthenia gravis. So anti-acetylcholine receptor antibodies or anti-MuSK in case of myasthenia gravis, anti-synthesis polymyositis or anti-Rho, anti-LA. So this whole antibiotic, what is called antibody panel or autoantibody panel, can be there in your hospital, which you can order if you are suspecting the autoimmune type of neuromuscular disorders. Okay, so this will be positive. and can detect specific disease. Now, regarding the role of imaging, so MRI spine is important. It can localize the spinal causes of neuromuscular disease or which are affecting like cord compression or transverse myelitis or abscesses, extradural abscesses, or even demyelination. Okay, that can be seen on MRI spine. So this has to be ordered. Now, regarding the role of CSF analysis, so you need to be focusing on the protein content. So, if the protein content is high, 0.5 to 2 gram, or with no increase in cells, so that will be suggestive of GBS. Okay, so this is also known as albuminocytological dissociation. So that will be positive in GBS. However, you should not forget other causes of high CSF protein like tuberculosis, neurosarcoidosis, or malignancy. Okay, the malignancy which has penetrated to brain. A WBC of more than 5 cells per millimeter cube is abnormal and it should raise the suspicion of infective causes. And later you can do the meningitic panel, the PCR for infective causes. Okay. So otherwise, it could also be possibly related to hematological malignancy like leukemia, T cell leukemia, or B cell leukemia. What is the role of skeletal muscle biopsy in ICU? Should we do it or not? That is debatable. But if the diagnosis is uncertain, with the help of neurologist, you can plan a skeletal muscle biopsy, especially for acute inflammatory myositis, because it is potentially treatable with immunosuppressive therapy. So this is only indication to do a skeletal muscle biopsy. Risk has to be explained to the relatives. Okay, but you have to rule out other causes as well. But if it is strongly suspected, inflammatory myopathies or myositis should be really indicating to. I mean, is a good indication for the skeletal muscle biopsy. Now, there is a question for you regarding the diagnostics. So, a 70-year-old man is admitted to ICU with serious sepsis secondary to community-acquired pneumonia. He develops multi-organ failure. Following ventilation for 16 days, attempts to wean from ventilation are unsuccessful. Examination shows diffuse weakness and hyporeflexia. Electrophysiological investigations show normal conduction velocities, a decrease in CMAP amplitude, and a normal SNAP amplitude with 5% decrement of CMAP amplitude on repetitive nerve stimulation and no increment response on exercise of the muscle. The CSF protein levels are normal. What is the most likely cause of this patient's weakness? So these kind of question based on the electrophysiological testing are expected. So you have to have a good knowledge about this. So what is your critical illness myopathy? Good. So most of the people are fit. It's okay, great. So these are abnormal findings, okay? As far as this. So we will rule out one by one. So Guillain-Barré syndrome is not possible. Okay, GBS because the sensory nerve action potential is normal. So it is not a possibility. Myasthenia gravis is also not possible. Lambert-Eaton syndrome is also type myasthenia gravis, so it's also not possible. So this is correct critical illness myopathy. So how it is correct, we will come to know. So these electrophysiological features are consistent with axonal degeneration and show low amplitude of CMAP and SNAP with near normal conduction velocity. So this is the thing, but we will explore it more in this slide. So role of neurophysiological studies. So what are the neurophysiological studies? First of all, we have nerve conduction study and electromyography. These two types of study we perform in ICU for neuromuscular diseases. And Nerve conduction studies basically can measure the nerve conduction velocity and nerve action potential amplitude. Okay. So sensory nerves are evaluated by stimulating them while recording the transmitted action potential. Motor nerves are evaluated by stimulating the motor nerves while recording the compound uh, action potential from innervated muscles. So what we see slowed nerve conduction, slow velocity or low velocity occurs when nerves are demyelinated, as we see in patients of GBS, okay, especially the demyelinating subtypes of GBS, where you will see the slow nerve conduction velocity. And LCS can essential, be used to differentiate demyelinating and axonal subtypes of Guillain-Barré syndrome. Then on other side, amplitude, action potential amplitude, the CMAP. The CMAP may be reduced, or this is compound. Basically, this is all we are compounding or accumulating all the action potential from the muscle, myofibrils in the muscle. So that is why it is called compound muscle action potential. So this will be reduced in case of axonal type of neuropathy in GBS. And if it is associated with an increase in duration, it suggests myopathy also. So this is the significance. And then reduction in the sensory part, that is SNAPs, suggests an axonal variety of neuropathy, that is axonal sensory neuropathy, that is the variety of GBS. So we will understand it more in GBS, what you call variants, the GBS variants.